My name is Lugarasi. I started to study sleep-related epileptic and non-epileptic motor disorders in the early 60s. One of our first patients to undergo polysomnographic recording was a Franciscan friar who had a severe form of restless leg syndrome. He presented violent muscle jerks in his legs, arising on falling asleep and persisting in sleep. Jerks recurred periodically about every 30 seconds. Nocturnal myoclonus is the name we coined for the disorder currently known as periodic limb movements. In 1965, Jung and Kolo in Germany and Gaston and co-workers in France made polysomnographic recordings of patients with Pickwickian syndrome, obese, hypersomnolent patients with periodic breathing during sleep. Jung and Kolo speculated that the nocturnal apneas in Pickwickian patients were a sign of hypothalamic dysfunction, like obesity and daytime somnolence. Gaston and co-workers, on the other hand, claimed the somnolence was secondary to recurring awakening caused by obstructive apneas. These findings aroused our interest. The wife of my co-worker Giorgio Coccagna was a keen young anesthetist and a great hand in devising a polygraph devoted to the study of the ventilatory and hemodynamic effects of obstructive apneas. We simultaneously recorded oral and nasal breathing, chest movements, endoesophageal pressure, the EMG activity of the diaphragm and intercostal muscles. By cannulation of the radial artery, we continuously monitored systemic arterial pressure, taking also arterial blood samples to measure pH and oxygen and carbon dioxide pressures during wakefulness and the different sleep stages. In addition, a microprobe was inserted retrogradely into the pulmonary artery for continuous monitoring of arterial pulmonary pressure. In the space of a few years, we collected an enormous amount of data that we presented at the meeting we organized in Rimini in May 1972. The meeting was attended by the few clinical neurophysiologists who were studying the topic, and some leading American and European breathing pathophysiologists. At the Rimini Congress, we documented that obstructive apneas have a major negative impact on alveolar ventilation and on the systemic and pulmonary circulation. We also show that by eliminating the obstructive apneas, tracheostomy leads to an immediate disappearance of somnolence and the massive nocturnal oscillations of pulmonary and systemic blood pressure. The results of the Rimini meeting were published in a leading international journal. Since then, sleep-related breathing disorders have become the focus of experimental and clinical studies all over the world. In the early 70s, we started to perform routinely our polysomnographic recordings under audiovisual control, and we discovered that motor attacks, until then confused with night terror and sleepwalking, were distinct and peculiar motor disorders characterized by abnormal postures and movements. But also by more complex behaviors like rocking body movements and rhythmic hand and foot tapping. In addition, patients often emit guttural sounds, implorations, or imprecations. They may even speak or whistle. As the evidence accumulated, we realized that most of these attacks are epileptic in origin and are correlated to epileptogenic foci located deep in the frontal lobe.